Okay, this is going to be chapter 40. This is the end of chapter 43, where we're going to cover MS and ALS, and then the rest of it is chapter 24, or I mean 44. So just make sure that you read the end of chapter 43. So the first thing that you'll have started with is multiple sclerosis. And so there's 4 different types of MS that we're going to encounter as a nurse in dealing with patients that have been diagnosed with MS. So the 4 here are listed for you, and each one kind of talks about, what it's kind of going to look like. It's outlined exactly how the book has it for you. So the relapse remitting, that's the most common type of MS. And so what happens with this is that their symptoms will develop and then will resolve within a few weeks to a few months. Your primary progressive, so this person unfortunately has just a steady and gradual neurological deterioration. So there is no relapse remitting. Like they have the relapse, and then with relapse remitting, they have the problems and then they resolve almost to baseline usually. Like a lot of them will go to baseline. There's some that don't go all the way back to baseline, but the majority do. Whereas primary progressive just keeps getting worse. This one is typically diagnosed between 40 and 60 years of age. So MS itself is typically diagnosed between 20 and 40 years of age, but primary progressive will have a diagnosis seen more often in patients that are 40 to 60 years of age. Secondary progressive starts out as relapsing remitting, and then becomes into a secondary progressive. So it begins with relapsing remitting and then later becomes steadily progressive. So half the people that are diagnosed with relapsing remitting MS develop the secondary progressive MS within 10 years of their first diagnosis. So if you're going to end up having secondary progressive, your patient is, they will have started with relapse remitting and then later on they turn into more of a progressive. And then progressive relapsing is frequent relapses with just partial recovery, and only small percentage of patients have progressive relapsing. So these patients are going to have their relapses quite often. They won't happen as infrequently as somebody with relapsing remitting. They'll be happening quite often, and their recovery part of it will not go back to baseline. So MS itself is a lifelong inflammatory disease of unknown etiology that affects the brain and the spinal cord. So you'll notice that from your book, it's the leading cause of neurological disability in young people. Periods of exacerbation, which are also known as flare-ups, and remission. But patients with MS do have a normal life expectancy. So your incidence and prevalence, I already mentioned the age. There's 400,000 people in the U.S. It happens 2 times as more often in women than men. And it's seen more often in colder climates and of people of northern eastern ancestry. So a lot of us that live here in Michigan, we do see this disease much more often in the states that have the colder temperatures and populations of northern eastern ancestry. So unknown etiology. So what happens in MS is that there's this inflammation that causes demyelination of the myelin sheaths in the brain. So normally the communication pathways are covered in what's called it's like myelination, okay? So it's this almost like if you think of a electrical cord, okay? It's wrapped around in this protective covering. So if you have your computer plugged in and the cord is laying on the ground, it's got this protective electric covering around it. And then the cat comes along and starts chewing it up. That is demyelination, okay? So it's going to disrupt the transmissions of the communication that the brain is trying to send, or like with your cord going to the computer to charge it, it's going to disrupt that, and then maybe sometimes your computer will charge and sometimes your computer won't charge because there's this disruption of communication. So the demyelination, where the body is attacking its own myelin sheaths, is what's going to happen and cause the symptoms in an MS. So if the person quite often will start stumbling or have a lot of times the optic nerve is affected and they'll lose vision. So what's happening is the brain is sending the signals to the eye for the vision, but it's not getting all the way through. It's only partly getting through, or it's getting disrupted. Or same thing with the brain is sending the message for the leg to walk and move forward, and the leg doesn't do it. So the person falls and stumbles, or it only partly does it because the transmission isn't getting there all the way. So the way that we see this is on an MRI is diffuse, random, or patchy areas of what looks like plaques in the white matter of the CNS. That's the definitive finding. They'll do a lot of other testing as well, including spinal taps and other things. But this is what we're going to know. This is what's important that we know, that they're going to see this patchy areas of what they'll call plaques, but that's actually where the demyelination is occurring. It's like these little scar patches, if you will, of where the myelin sheath has been eaten away on the different and through the pathways. So hopefully that makes sense. And then the next we're going to talk about is Lou Gehrig's disease, also known as ALS. So this is characterized by progressive weakness, muscle wasting, and spasticity that eventually leads to paralysis. So with ALS, this is a really unfortunate illness. It begins in one area of the body and spreads until the inability to talk, swallow, and breathe eventually occur. The upper neurons in the brain have broken connections with the lower motor neurons, and so spasticity occurs in the muscles. And if you don't understand spasticity, there's a link right here for you that you can go and read up on that. So what's going to end up happening is a person's muscles are going to weaken, they're going to atrophy, and they're going to die. And sadly, the patients usually live anywhere to up to 3 years after diagnosis, and death is typically the result of respiratory failure. So there's no known cause or cure, no standard progression, no specific treatment, and no method of prevention. So very difficult to take care of a patient with ALS, and very difficult for the patient to go through this. All right, so now we're going into Chapter 44, care of patients with peripheral nervous system, also known PNS, peripheral nervous system problems. So the PNS is composed of spinal nerves, cranial nerves, and part of the autonomic nervous system. For you to better understand what's happening, this video here for the autonomic nervous system, it's called Crash Course. It's really good. I watched like 6 different videos trying to find the best one for you guys, and this one was by far the best. So please watch that first so you can kind of understand the rest of this. I want to say it is approximately about 10 minutes, but this is going to help make sense of so much more things as we build on later on, both in Pharm and MedSurg 1, because it's going to teach you all about the sympathetic and parasympathetic nervous system as well. So please go and watch that video. So the first PNS issue we're going to discuss is going to be Guillain-Barré syndrome. And that is the way that I learned to pronounce it, and I believe that's right, Guillain-Barré. It's an inflammatory process that affects the axons and myelin of the PNS, causing motor weakness and abnormalities in sensory perceptions. So it's an uncommon disorder. It affects males slightly more often than females, peaking after the age of 55. So here's the symptoms that the patient's going to endure. It's typically going to begin in the legs and spread to the arms and the upper body, and this is referred to as ascending paralysis. Makes sense? It's starting at the bottom and moving up. Ascending paralysis. Paralysis can increase in intensity until the patient becomes totally immobile. Some patients are going to have to be on a ventilator because of their diaphragm being paralyzed or weakened. When I worked in the ICU, I took care of a couple different patients with Guillain-Barré, and they were on ventilators. And then the healing occurs in reverse order. So whatever was last to go is the first to recover when the function returns. So there's 3 separate stages of Guillain-Barré syndrome, And your first is, it's going to happen within the first 1 to 4 weeks, is the acute or the initial period. So this is the onset of the very first symptom, and then it ends when there's no more deterioration. So after the ascending paralysis has happened, once it gets to wherever it's getting, and then there's no more deterioration. So that can be different for different patients. It doesn't mean that it has to get all the way to the point where the patient can no longer breathe. And then there's the plateau period, that's several days to 2 weeks typically. And again, this could vary a little bit for people, but this is where they're going to stay at that level of deterioration. Nothing's going to get worse and things aren't really going to get better. And then there's going to be the recovery period. And look at how long. So this happened really quick. This happened within 1 month's time. And then the recovery period takes anywhere from 4 to 6 months, but can go all the way up until 2 years. The recovery period is thought to coincide with remyelination and axonal regeneration. And then there are some patients that do not fully recover and have permanent neurological deficits, and this would be called chronic GBS. So our plan of care, there's different diagnostic testing that is talked about in your book that you can read about when you read about GBS, but the priority nursing care. So we're definitely watching the respiratory status. We're seeing, especially with that ascending, once it's moved up past the legs, we're going to be watching our patient's respiratory status and determining what kind of respiratory care they need, what kind of assistance they're going to need. We're also going to be watching their cardiac status because the sympathetic and parasympathetic nervous system can be affected with this. So they both, I don't want to call them competing, but they're going to be going back and forth with one another. So I could definitely see things going on with the heart, things going on in the GI tract. All kinds of stuff could happen, but cardiac anyway is what I was trying to focus on there, especially for arrhythmias and PVCs and things of that nature, which we'll learn more about when we get to cardiac chapters. Pain management, your book talks about how patients with pain with GBS have much more pain at night typically, and they're very sensitive to touch. So we need to make sure that we're making them as comfortable as possible. And, that may mean a blanket or a sheet that's laying on them is causing them a bunch of distress. Talking with the patient, depending on how bad and how weak they are, it's gonna depend on the way they're able to communicate. And then emotional support. Or remember, they were up and vibrant and functioning just like me and you, and then this happened to them and they went down within a month. And then their nutritional status. This is something that, depending if the patient loses is too weak to eat, they could end up having NG, and we could be doing replacement foods. And, the book also talked about offering a very high protein snack instead of a lot of meals, so the patient doesn't become as tired. And then the medical treatments, they have IV immunoglobulin therapies and then plasmapheresis. So read about plasmapheresis in your book. The page for that was 920. So what plasmapheresis is it's a blood procedure. We remove the circulating antibodies that we believe are the ones that are causing the disease. And so what happens is the plasma selectively, we separate it from the whole blood and we return the blood to the patient without the plasma. Plasma itself typically replaces itself or is transfused with albumin, but your book talked about how we do not use fresh frozen plasma because it can be associated for patients with GBS to have a risk of infection or allergic pulmonary edema, so they don't do that. So I'm going to actually stop right here and then pick back up with myasthenia gravis when I do my next one here. So I'm going to stop and then I will resume in just a moment.